Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club on kidney evaluation of living kidney donor candidates is hosted by the AST Living Donor Community of Practice. In a moment, I will turn the session over to our moderator, Dr. Angie Nishio-Lucar from the University of Virginia. But before we begin the main presentation, we have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This Journal Club is being recorded, and the archive will be available on the MyAST website 1 to 2 business days after the live session. Please note that all of your lines have been muted so that only the presenters can be heard for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate using the Q&A section of the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat window may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline or we will post a full answer to the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Nishio-Lucar, to begin today's presentation.
Thank you, Brian, and good afternoon to all of you. I'm Angie, Nishio-Lucar, a transplant nephrologist at the University of Virginia. Today, I have the pleasure to moderate the session discussing a paper published last year in AJT titled The Kidney Evaluation of Living Kidney Donor Candidates, U.S. Practices in 2017. We will also review selected aspects of the companion paper published in the same journal volume titled Metabolic, Cardiovascular, and Substance Use Evaluation of the Living Kidney Donor Candidates. Our speaker today is Dr. Neetika Garg, the first author of today's paper. She's a transplant nephrologist and an assistant professor of medicine at the University of Wisconsin. And our goal is to follow Dr. Garg's data presentation by an engaging discussion facilitated by our two excellent panelists, Dr. John Gill, professor of medicine at the University of British Columbia in Vancouver, Canada, and AST president-elect, and Dr. Nicole Turgeon, Division Chief of Transplant Surgery at the University of Texas at Austin Dell Medical School. Without further ado, I'm going to turn it over to Neetika Garg. We look forward to hear your presentation.
Hi, everyone. Thank you, Dr. Nishio-Lucar, for the introduction. And I also want to take the opportunity to thank the American Society of Transplantation for the invitation to present the results of our survey on kidney evaluation of living kidney donor candidates. I do not have any relevant financial relationships to disclose. So starting with a little background, as we all know, living kidney donor transplantation is the best renal replacement therapy option for eligible patients with end-stage kidney disease. The practice of living donation requires thorough evaluation of candidates and careful assessment of short-term and long-term risks, most notably of end-stage kidney disease in the donors. Since living donation is an area where overall long-term data in the context of several individual risk factors are limited, it is important to document practices at any given point and how they have evolved over time. The last survey of transplant programs in the US to document clinical practices as part of donor evaluation was published over 10 years ago, and I've referenced the two publications from AJT on this slide. Since there has been significant advancement in our understanding of kidney outcomes in the donor population since the time this last survey was published, and how we view risk in this population. One of the most important studies in this field is a study by Muzale et al., which was published in the JAMA in 2014. This study evaluated the risk of kidney failure in living kidney donors. They had 96,000 plus a few more kidney donors that had donated in the United States between 1994 and 2011, and about 20,000 controls from the NHANES and CMS database. The absolute risk of kidney failure among these donors was 30.8 per 10,000 after 15 years of donation. The median follow-up in this study was about 7.6 years. There was some concerns, some limitations in the choice of control group and the matching procedures that were used. That being said, the risk of kidney failure amongst healthy non-donors was 0.14%, and the risk of kidney failure amongst donors was 0.9%, yielding a relative risk of about 6.4. The 0.9% risk was still substantially lower than the risk of 3.26% in unscreened donors, but about 6.4 times higher than healthy non-donors. So we are aware that decision-making in living donor evaluation is complex, and the existing literature provides limited guidance regarding evaluation and decision-making in individual candidates. The process of evaluation is highly nuanced, and there is strong emphasis on risk-benefit discussion and informed consent. So this uncertainty commonly prompts physicians to clinicians to reach out to colleagues in the transplant community to discuss the challenges and controversies in the evaluation and selection of some higher risk donor candidates. And we all see emails coming through the ASD's Living Donor Community of Practice listserv. So we conducted an updated survey of US transplant programs to document current practices and how these have evolved as a result of the new data and guidelines that have become available. The results of our survey are available in the form of 2 publications in the AJT from last year. Briefly going over our methodology, we had a 59 question survey. The survey was sent out in 2018 and specifically asked about practices in 2017. We retained questions from the 2005 survey as much as possible. The survey was done in collaboration with UNOS and was first sent out in mid-2018, followed by 2 reminder emails. And then UNOS provided de-identified responses back to us. And we tried to compare the results to the previous survey results whenever possible. The survey was sent to 446 program directors from 223 programs across the country, and we heard back from 71 program directors from 69 programs. So the program response rate was 31%. A large number of topics was covered under the survey. For the purposes of this discussion, I will focus on the topic of age, kidney function, proteinuria, ApoL1 genotyping, hematuria and stones, blood pressure, and BMI in donor candidates. So starting with age, I'll orient everybody to this graph. So the results from the present survey, so the 2017 survey, are highlighted in the black bars, and the results from the previous survey, the 2005 survey, are in the gray bars. So in 2017, we asked about the upper age limit beyond which donors are excluded. The most common upper age limit is reported by 2/3 of the programs. 2/3 of the programs reported that they do not have an upper age limit. Amongst the programs that do have an upper age limit, the most common exclusion threshold in 2017 was 70 years as opposed to 65 years in 2005. So based on this, I would say that since 2005, transplant programs have tended to become slightly less strict in terms of the upper age limit for exclusion. We also asked about the lower age limit below which donors are excluded. In concordance with the OPTN policy for living donors, all programs in 2017 specify a lower age limit. The most common lower age threshold remains 18 years, although the programs using this threshold in 2017 was 65%, decreased from 77% in 2005, with the p-value approaching significance. The survey gave the respondents the options of adding comments, and a lot of respondents noted that in the 18 to 25 age groups, very careful psychological evaluation is usually needed, sometimes including psychiatric evaluation. So in terms of age, programs have become more careful with younger candidates and have become somewhat relaxed in their criteria for older donor candidates. Next, moving on to kidney function, we asked programs what kidney function tests are routinely performed in all candidates. As you can see, eGFR and creatinine are universally performed. The OPTN policy in the US mandates measuring either the 24-hour creatinine clearance or measured GFR. And despite its limitations, an overwhelming majority of the programs in the US continue to obtain 24-hour urine creatinine clearance in all donor candidates. But one of the more substantial changes that we observed was that 30% of the programs, so nearly 1/3 now, obtain a measured GFR compared to only about 11% in 2005. Adjustment for body surface area is important. So as an example, we have two individuals here. On the left is a smaller person with a body surface area of 1.5 meters square. And on the right is a bigger person with a BSA of 2 meters square. If we say that they both have a GFR of 100 mils per minute, that gives the person on the left a GFR of 100 mils per minute per 1.73 meters square. And the person on the right, a GFR of 86 mils per minute per 1.73 meters square. Adjusting any GFR measure for body surface area allows using the same GFR thresholds across the range of body size for decision-making regarding donor candidates. And the assessment of donor safety should be based on the adjusted or the normalized GFR or creatinine clearance, as has been recommended by several guidelines. However, in our survey, we found it surprising that 1/4 of the programs do not routinely use this adjustment. Next, we asked program their criteria for exclusion based on kidney function. And 3/4 of the program, essentially unchanged from 2005, noted that they use an absolute cutoff of 80 mils per minute per 1.73 meters square, and nearly 1/4 of the programs, similar to 2005, use a age-adapted cutoff, where they exclude donors if the GFR is less than 2 standard deviations below mean. We also asked programs about their practice in candidates with a significant difference in kidney size. And the most common practice, as noted by 67% of the programs, was to obtain split kidney function testing using a nuclear scan to determine which kidney should be used for donation. And about 1/4 of the programs noted that they routinely just procure the smaller kidney. So to summarize the section on kidney function, a threefold increase in the number of programs that routinely obtain measured GFR in all donor candidates was observed. Despite its limitations, a large majority of programs continue to obtain 24-hour creatinine clearance in all their donor candidates. And when assessing for donor safety, GFR should be adjusted for body surface area, although we noted in our survey that only 3/4 of the programs do this routinely. And a large majority of programs still use a fixed GFR cutoff of 80 for all candidates, and about 1/4 use age-adapted cutoffs. Moving on to the question of proteinuria, we asked programs which proteinuria assessment measures are routinely used by them. And as you can see, we asked about the qualitative dipstick, 24-hour urine proteins excretion, 24-hour albumin excretion, spot urine protein to creatinine ratio, and spot urine albumin to creatinine ratio. And the most notable change in the evaluation compared to 2005 was the increasing reliance on albumin-based measures. Specifically, urine albumin to creatinine ratio in 2017, half the programs obtained a random spot urine albumin to creatinine ratio, as compared to only about 20% in 2005. Next, we asked programs about the exclusionary criteria they use based on proteinuria. And while more programs are using albumin-based criteria, the most common criteria remains based on urine protein to creatinine ratios. 39% of the programs use a urine protein to creatinine ratio or total albumin proteinuria per day of 300 milligrams per day as an exclusionary criteria. And 25% use proteinuria greater than 150 milligrams per day as an exclusionary criteria. In terms of albumin-based criteria, 22% of the programs noted that if the urine albumin to creatinine ratio or albuminuria greater than 30 milligrams per day is noted, they exclude the donors. I will make a note that the 2005 survey did not evaluate exclusion criteria based on urine albumin to creatinine ratios. Moving on to APOL1 genotyping, about 40% of African Americans on dialysis in the United States carry the APOL1 high-risk genotype. And we do know from prior data that most African-American donors, more than 80%, are first-degree relatives of their recipients. So this has obviously generated a lot of interest in APOL1 genotyping amongst the donor population. So we asked which centers test for APOL1 genotype in their African-American candidates. And the results we obtained showed that 13% routinely do this testing in all their candidates, and 32% do it selectively. So 45% of the programs do APOL1 genotyping either routinely or selectively in their candidates, and 55% never do. Next, we asked what programs do if they do find a high-risk APOL1 genotype in their candidate, and half, 52%, reported that a high-risk APOL1 genotype is an absolute exclusion criteria at their program, and the other half, 48%, reported that the finding of high-risk APOL1 genotype factors into their decision-making and informed consent process, but is not an exclusion criteria by itself. So penetration of APOL1 genotyping in the African-American donor candidate population is low, and it makes you wonder whether it's related to the access we have to this testing, or it's related to lack of consensus on how to use results. The NIH-sponsored Apollo is charged with prospectively assessing the effects of renal risk variants in the APOL1 gene on outcomes for kidneys from donors with recent African ancestry, both after deceased and living donor transplantation. And I'm hoping the results of the study will be helpful in guiding how to use this testing in the donor population. Next, moving on to donor candidates who have persistent isolated hematuria. Programs are now more willing to evaluate candidates with persistent isolated hematuria. This was an absolute exclusionary criterion at 21% of the programs in 2005, but in 2017, only one program responded that they exclude donor candidates with hematuria. And as shown in this graph, the most common practice now is that programs require both urologic evaluation and kidney biopsy as part of the evaluation of these candidates. As we do more biopsies for hematuria, we're bound to find more diagnoses like thin basement membrane disease. And we had a question for respondents asking what they do when a finding of thin basement membrane disease is found on the biopsy. And a little less than half noted that they routinely exclude patients with this diagnosis, donors with this diagnosis. Thin basement membrane disease is generally considered to be a benign disease, but there is still uncertainty about its prognosis, whether we are missing FSGS lesions, and in the case of women, whether it represents the Alport's carrier state. So that explains some of the uncertainty and variability in how programs handle donor candidates with thin basement membrane disease. Next, we had questions about donor candidates with prior symptomatic stones. And in 2017, only 10% of the programs routinely exclude donor candidates who have a history of symptomatic stones, as opposed to about 25% in 2005. And the most common practice, as noted by the second bar in the graph, is that the donor candidates are accepted if no current stones are present and the urine profile, the 24-hour urine analysis, is low risk. An additional quarter of the programs require a 5-year wait period, symptom-free period, before accepting these donors. In addition to the questions regarding symptomatic stones, our 2017 survey included 4 questions regarding asymptomatic stones, specifically whether programs would accept candidates with incidental findings of small stones on imaging done as part of donor evaluation. And 95% noted that they would accept a candidate with single small stone on one side if the urine stone risk profile was completely normal, and 80% would accept a candidate with a single stone on one side and if an easily correctable factor on the urine stone risk profile was found, for example, low urine volume or low citrate. Several responding programs noted in their comments that they would favor removal of the kidney with the stone. If the stones are bilateral, the number of programs that would accept or consider these candidates dropped substantially to 48% and 33%, depending on what their stone profile looked at. The 2005 survey did not inquire about these specific questions. So summarizing the section on stones, nephrolithiasis is very common in the general population, but an uncommon cause of end-stage kidney disease. Risk is likely to be higher after donation in the setting of having one kidney, especially if it is estimated that there is a risk of recurrent stones. Programs appear to be reluctant to accept donors with small asymptomatic stones and normal or low risk profiles, especially if stones are bilateral or if the kidney with the stone cannot be procured for donation. In our survey, the laterality of stones could not be explored, was not explored. Moving on to donor candidates with history of hypertension. So the programs overall have become significantly less restrictive over the last decade in terms of accepting candidates with hypertension. The most common practice in 2017, reported by 65% of the programs, is to exclude candidates requiring 2 or more antihypertensive medications. So in other words, if hypertension is well controlled on one medication, that is considered acceptable. This is in contrast with the 2005 survey, where the most common practice reported by half of the programs was to exclude candidates taking antihypertensive medications. So next we asked the question on hypertension by race. So for programs that reported in the 2017 survey that they accept candidates with well-controlled hypertension on medications, we asked about differences in selection criteria between African Americans and non-African Americans. Non-African Americans are represented in the lighter bars, and the African Americans are represented by the darker bars on this graph. So for non-African Americans, the most common practice reported by 32% of the programs was that they accept if there is no evidence of LVH, left ventricle hypertrophy, on echocardiography, and another 30% reported that they accept if there is no evidence of LVH and the candidate is above a certain age, and the most common age cutoff that was cited was 50 years. In contrast, the most common response for African Americans reported by 42% was embedded in the other option, stating that African Americans with hypertension are routinely excluded. How the selection criteria differed amongst African Americans compared to non-African Americans was not explored in the 2005 survey. So programs are generally more accepting of hypertensive donor candidates now than in 2005. The exception is African Americans, and this again brings us back to the APOL1 genotyping questions. And I just want to make a note that there are very few studies evaluating pre-donation hypertension as a risk factor for post-donation outcomes. Next, moving on to the question of BMI. The most common cutoff for exclusion based on BMI is 52, and it was the same number is 35, and the percentage of the programs reporting this cutoff, 52%, was the same as in 2005. However, the most notable change was that compared to 2005, fewer programs are using higher BMI cutoffs. So in 2005, nearly 1/5 of the programs reported using cutoffs of 40 or higher, but in 2017, only 4% of the programs reported using cutoffs of 40 and higher. And this change may be related to some of the data on obesity and outcomes in the donor population that has been published. This one study published by Locke et al. In Kidney International in 2017 showed that the hazard ratio for obese versus non-obese for development of end-stage kidney disease was 1.86%. Specifically, for each unit increase in body mass index above 27, there was a 7% increase risk in end-stage kidney disease. So these were I've summarized some of the data from our survey. Two important limitations I would like to list. One is recall bias. The findings represent practices as they were reported. We cannot verify how accurately they represent actual practice. And second, the response rate of 31% is a limitation. I will note that we looked at practices and if they varied based on program size, UNOS region, whether the program was an academic center or not, pediatric or adult kidney transplants only. And overall, we did not find any differences in practices. So I do believe that our results represent national practices, even though we had a response rate of 31%. So to briefly summarize, programs have generally become more careful with younger candidates and obese donors over time, but less strict in terms of older candidates or candidates with coexisting medical conditions like hypertension, hematuria, and stones. There has been a lot of work done in the GFR evaluation since the last survey. However, practices in terms of what GFR assessment methods are used and what exclusionary criteria are used remain mostly unchanged. I'll circle back to this Muzzali et al. Study from the JAMA from 2014, which showed that the absolute risk of kidney failure in living kidney donors is 30.8 at 15 years. As I noted earlier, the median follow-up in this study was 7.6 years. This study was published subsequently, which extended the horizon in terms of how far we are looking out at the kidney failure risk. And the kidney failure risk at about 22 years is 49 per 10,000. As you can see, the graph is not linear. The risk of kidney failure in the initial few years is quite low, but tends to go up as time goes on. And we have learned that not only is the risk of end-stage kidney disease not linear, we also know that the cause of end-stage kidney disease varies by time since donation. So this study that was published a few years ago in the AJT looked at the risk of kidney failure in the first 10 years after donation, and then the subsequent 15 years, so between 10 and 25 years after donation. And the risk went up from 10 per 10,000 to 85 per 10,000 at 25 years. They also looked at the causes of kidney failure in the donors. And if you see the three graphs, the one on the left represents diabetes-related kidney failure. There were very few cases of diabetes-related kidney failure in the first 10 years, but substantially more in the subsequent 15 years. The graph for hypertension-related kidney failure represented in the middle showed a similar shape. Very few cases in the first 10 years, but substantially higher at 10 to 25 years. The graph for glomerulonephritis-related kidney failure is relatively flat, and the risk was essentially unchanged between the first 10 years and the subsequent 15 years. So in other words, the risk, there's an increase in late post-donation risk, and it is mostly attributable to diabetic and hypertensive kidney disease. In other words, extrapolations of post-donation kidney disease risk based on the first decade of follow-up substantially underestimates the risk of kidney failure in the subsequent decades, especially for diseases which have delayed expression and a long prodrome, such as hypertension and diabetes, which explains why programs have become more careful with younger candidates. So to summarize, our survey documents current practices and how they have evolved over time. They can serve as a reference guide for programs inquiring about practices and donor evaluation in the country. And last but not the least, our survey underscores the importance of ongoing research focused on long-term outcomes. I would like to acknowledge the UNOS team and all my co-authors who helped us conduct this survey. And I will hand over the mic back to Brian to start the discussion and question section. Thank you.
Thank you so much for that excellent presentation, Dr. Garg. I would like to take a moment to invite all of our panelists to turn on their webcams and audio, and we will begin the gallery Q&A discussion. Dr. Nishio-Lucar, if you could take over, thank you so much.
Thank you, Brian. Thank you, Dr. Garg, for such a great presentation. To open the Q&A session, our audience is highly interested in asking questions about the removal of eGFR from the eGFR equation. And I'll start with a comment from and question from Dr. Marta Lavakis from Beth Israel Canada. So Dr. Palvakis says that one objection to dropping the Black race variable from creatinine-based EGFR formula is that Black potential living donors will be ruled out if these formulas are used. But these formulas are inaccurate when applied to people with good kidney function, and in my opinion, should not be used as a test for kidney function in the donor workup. Could you please comment on the use of creatinine-based EGFR formulas in the kidney function testing of a potential donor, even as a screening test? Dr. Gill?
Yeah, thanks. Nice to see this question from Martha. Martha, I think I agree with you. I think for any screening test, whether it be GFR estimate or something that's imprecisely collected by primary care or subject to, analytical variations in accuracy, I think our perspective on living donors should be that these people are coming forward to do something benevolent. And, our need to screen out people, it would be a great problem if we had so many donors that we could, use imprecise measures to exclude donors from consideration. In our program, we do check estimated GFRs, but we rarely will exclude people on the basis of that alone. At an early stage, we think that we know that tests can be inaccurate. So whether we're talking about GFR or some other test, I think our perspective really should be to fully evaluate people, because as we all know, there's very few absolute contraindications to living donation. So I share your concern, but I don't think it's necessarily just specific to the EGFR issue.
Thank you, Dr. Gill. Dr. Turgeon, do you have anything else to add?
Thanks, Martha, for that question. And John, thank you for that explanation. I support exactly what you've said. I think it's interesting because I'm not really used to using EGFR as a screening test, and I don't think that it's a really good one. In fact, in our program, we were just starting with 24-hour urine collections. And so I think we really need to be cautious about setting strict limits on tests like EGFR and really need to think about things in the context of all the other elements that are in an evaluation. I'm concerned about using EGFR in general as a cutoff for all donors rather than just donors who are African American. So I think that would be my point on that.
Thank you, Dr. Turgeon. There is another question from the audience pertaining obesity. So obesity is increasingly more prevalent, and there is a recognition that higher BMI, of Dr. Garg pointed out during her talk, that increases the risk for metabolic complications and end-stage kidney disease. And many programs may have absolute BMI cutoffs, as Dr. Garg showed us, for acceptance of live donors. Is there an absolute BMI where a living kidney donation should be discouraged? Should potential donors undergo some counseling or weight loss program in order to attain a given BMI to be acceptable? Dr. Garg?
Yeah, I think it's a really difficult question. So prior studies have shown, we know that the average BMI in the US is going up. We know that the average BMI in all subgroups, in most subgroups in the US is going up. And concordant with that, the BMI per age group amongst the donor population is going up. I think the data, we always do the risk assessment in the setting of, we always take multiple risk factors into account. It's hard to exclude somebody based on an individual risk factor unless it's really, unless it's something like diabetes, which is required by the OPTN policy. So most programs, have a cutoff, and 35 is the most common cutoff, but we do know that the risk of ESRD post-donation starts increasing at much lower. So 35 sounds like a reasonable number, and that is what we use at our program. But I am aware of a couple of programs that use much higher cutoffs, so potentially 40. And I think 4% of our respondents in our survey noted using a BMI cutoff of 40.
Thank you. Dr. Gill, is that similar to what your practice is? Do you have a BMI cutoff?
I think the answer that Dr. Garg provided is actually right on the mark. Let's just go back to our theme of how accurate BMI assessment is, first of all, whether we should be using waist circumference or something different. And then, does BMI really accurately reflect the, sort of body habitus associated risk of metabolic syndrome, future cardiovascular events, or kidney disease? And is BMI actually a good measurement in people of different ethnicity, et cetera? So given all of those uncertainties, it is an absolute cutoff. We all love to have the world be black and white, but it's not. So I think, having, general guidelines around BMI is important, but I agree it's a much more comprehensive assessment. So certainly if you ask me, are we going to really proceed with a living donation in somebody with a BMI over 40? I think it becomes a much more of a consideration. So, but there is healthy phenotypes of people who are overweight and have high BMI. And I think it does need a comprehensive risk factor assessment. So I shy away from absolute cutoffs, but truthfully, if you ask me in our program, are we, proceeding with donors very frequently with donors over 40, I would say it's very infrequent. But having said that, I don't think it's black and white.
Thank you. There's another question, shifting gears a little bit, from Dr. Bhavna Chopra. And she wonders what the thoughts of our panelists and our speaker about accepting African-American donors who are heterozygous or homozygous to APOL1 gene mutations. Dr. Turgeon, would you like to comment on this?
Sure, I think that's a difficult question and one that is evolving over time as we learn more about the APOL1 story. I think it does give you pause when you do have a donor that tests homozygous for APOL1, and I think you need to have a really good conversation about the potential risks and outcomes for that donor. I also think it depends on the age of the donor, the relationship to the recipient, and are you confident with that donor and that they're going to follow up? There are so many different aspects to donation and care that, again, this isn't an easy yes or no question like all the other questions. You have to take it in the context of all the other factors when you're doing the evaluation. So that's a longish answer. The short answer is I think I would take it on a case-by-case basis, taking all the factors into consideration.
Absolutely. Yeah. Yes, please go ahead.
I'll just add very briefly. I agree with Nicole, as I usually do, but I think the real issue is we all know that the bulk of the information about APOL1 is in the setting of deceased donor outcomes. There's very limited data. We know there's an ongoing study which thankfully will include information about living donors. So I'd encourage everybody to obviously support that study, would be the first thing. But I think that, when we look at those actual cases where there was high-risk APOL1 genotypes, the time course to the development of kidney function is very unnatural. So, it again brings into the consideration of, were there other considerations in those particular donors? And APOL1 is one of many of those. So I think that, again, we love to have, a go, no-go test, right, for donors, but I don't think it's that simple. So I think, what Nicole said is absolutely correct at this point in time. The other piece of it, though, is whether to do the test at all or not. And I think that is a discussion. We all see donors with different levels of health literacy, different levels of understanding. And so I think that's a really interesting question, right? There's a question of whether you should do the test, yes or no. And I was always taught, if you don't know what to do with the answer of the test, then don't do it. But I'm not so sure it's that clear here. So I think there's much more nuanced discussion with your potential donor about, should we do the test? What would we do with the information? Would it change our decision making? Those are, I think, thoughtful discussions that we have to have, and I don't know the right answer for that. I think it is variable depending upon the donor that you're evaluating.
Thank you. Dr. Garg, we have some attendees that were wondering along the lines with the B3 as previously discussed about if you have some data perhaps about diabetes and donor selection practices, and specifically about hemoglobin A1C as a cutoff for a donor.
Yeah, so we didn't specifically ask about diabetes because in the US, as per OPTN policy, diabetes is an exclusion criteria, although I know it's different in some European countries. But we did ask about pre-diabetes. We asked about glucose tolerance testing and what exclusion criteria programs are using. So in terms of glucose tolerance testing, a lot of programs, it's a test that's frequently performed. So if the fasting glucose is high, or if the A1C is high, but not in the diabetes range, or even with strong family history of diabetes or history of obesity, programs will do glucose tolerance testing. In terms of what exclusion criteria are used, again, as with everything in living donation, it's always dependent on what other risk factors you have. So a lot of programs do exclude pre-diabetics, but a lot of programs also noted that they'll exclude pre-diabetics in the presence of other risk factors. So if somebody's pre-diabetic and obese, then they would exclude, but if they're just pre-diabetic, they may not exclude. Exclusion criteria obviously also depend on age. There's a couple of graphs in the paper. I would recommend referring back to those graphs, but yes, we did ask about pre-diabetes, and there is significant variability between programs in terms of what they do and how they handle pre-diabetic donor candidates.
Thank you. Going back to the GFR question, but in this case, not particularly surrounding race, somebody from the audience asked about, recognizing the caveats and the limitations from estimated GFR. That's nonetheless what we use to monitor often donors living donors following donation. So what are your thoughts about using this tool as a follow-up, since it is recognized as inaccurate? Is there an opportunity to use a different method, such as a measured GFR following kidney donation? Dr. Gill?
So this is from Bob Metzinger, right? So Bob, it's a great question. This survey didn't focus on post-donation follow-up, which I think would be a fascinating follow-up study for this. I'm recognizing the limitations of the eGFR. I think once you get a sense of how inaccurate it is, it's a pragmatic choice. So in our practice, we will primarily rely on eGFRs once we've sort of figured out the fudge factor. So I look, stability of that eGFR. So yes, it's inaccurate with the measured GFR, but if I know what that fudge factor is, and I'm then longitudinally following that, in a series of labs, and I review labs on donors, as many of us probably do post-donation, then I think I'm comfortable with that. But I'm sure there's variation in practice around this for sure.
All right.
Not the greatest answer for Bob, but.
All right. Dr. Garg, was there any information that you identified in your study about utilization of ambulatory blood pressure monitoring studies to assess hypertensive donors?
Yeah, we did have a question about when programs do ambulatory blood pressure monitoring, and the most common answer was that if the donor blood pressure, if the blood pressure is greater than 140 systolic and the diastolic greater than 90, I think 2/3 of the program said that they would do ambulatory blood pressure monitoring. Slightly less would do if the blood pressure is borderline in the 130 to 139 range, and 85 to 89 diastolic range. If I remember correctly, about 40% of the programs do ambulatory blood pressure monitoring for all patients who are on medications, and then maybe slightly less than those with history of hypertension. So definitely used quite a bit in terms of evaluation of donor candidates, but also a lot of variability between programs as to what the exact indications for its use are. It's also not clear because the definition, the guidelines on how to define hypertension have evolved a lot in the last few years. And I think when we did the survey, the most recent AHA guidelines had just come out. So a lot of controversy around that, but ambulatory blood pressure monitoring does appear to be used quite often in donor evaluation in the United States.
Thank you. There's in addition another question about, since you pointed out that the survey found there was a shift of the upper limit of age for selecting living kidney donors from 65 to 70 years old. But should they be an upper limit of age for living kidney donation? Dr. Turgeon, do you have any thoughts of this?
Yeah, I think it's sort of like deceased donors where there shouldn't be an upper age limit, and it needs to be based on the health of the donor or potential donor. And just like all other donors, you have them proceed through a full evaluation, looking for the same things: high blood pressure, diabetes, stones, GFR, all of those important factors when you decide who's a donor. And also, you want to certainly make sure that they're fit enough to undergo surgery and be well after surgery. And I think in our program, we had done several donors in the 65 to 70 age range, and they did really well. So I think we need to change our mindset a little bit about that.
Yeah, absolutely. In our program as well, we used to have a cutoff up to 70 years old, and we previously were somewhat strict about that cutoff, but we learn and to get used to utilizing these donors, and actually they have excellent outcomes, and they are frequently incredibly vested in the process and follow up. So we have had a few donors as well over age 70, which have been exceedingly successful. Thank you for your answer.
Yeah, the only thing I'll add there is that I agree with you. We have definitely shifted practice towards evaluation acceptance of older donors. I'll often tell people that, look, we might turn you down, but you going through the experience, first of all, you'll be able to sort of, walk the talk. People are trying to identify living donors. And so it's not the end of the world if we end up turning you down at the end of it. So I think setting expectations is important. But I always tell turn down donors that, look, you still have a role to play. And in fact, you have what I call street cred in terms of, you came forward, you were willing to be evaluated to help somebody. And that sometimes motivates and is important for other potential donors to come forward. So I think setting expectations and letting people know that, look, even if we turn you down at the end of that process, you get a good health workup, and potentially you might motivate other donors, and we encourage those people to stay involved in helping their recipients identify a donor. So I think it all depends on your messaging and so forth, but I don't think we should be excluding people on age alone.
Thank you.
Can I make one more comment about obesity? It just sort of has been lingering in my mind. I think it's important to mention. It was sort of in the chat. One of the questions people often ask is, should we make them lose weight and to achieve a certain BMI? And I think that's a really hard question. And I think we all want donors to do that. And we were counseling them, telling them it's good for their overall health, which I completely agree with. But at the same time, what often happens is many of the donors will lose the weight to achieve what our goal is. And then you'll see them in follow-up, especially now that we're following a little bit longer and seeing that BMI creep back up after donation. And the question becomes, well, was that really worthwhile? Did we delay donation as a result of asking them to lose weight? And so, as much as I want donors to be healthy and be in a certain BMI that we consider non-obese, I'm not sure that weight loss requirements is the right thing to do. But, we're evolving and learning new things every day. So I just thought that would be important to mention as part of this discussion as well.
Yeah, I'll just take off on Nicole's comment there. I think, if we're asking people to lose weight to make, our cutoff, our real emphasis should be, if we ask them to do that and they do take the weight off, what are we doing to help them maintain the weight that they take off? And I think the same comment now applies to older donors. If we expand our evaluation of older donors and we accept people with, let's say, isolated medical abnormalities, whether they be hypertension or, a GFR cutoff that's a little bit lower than, we are normally used to seeing. The question is how are we supporting them after the donation? What's our interaction with their primary care doctors? So that we manage their care afterwards. And so I think the big issue really is shifting our practice a little bit in terms of extending what we think about after the donation is probably way more important.
Yeah, sometimes, I mean, I haven't encountered this very often, but sometimes there are, as you know, donors tend to be highly motivated and they really want to help their intended recipient. And in the process of doing that, oftentimes they're willing to put themselves through unusual testing and more extreme situations. So I have had the occasional donor where they were motivated or interested in pursuing weight loss surgery in order to make themselves eligible. How would you, manage a situation like that, Dr. Turgeon?
Yeah, I think that again is kind of learning about the donor and what other factors they have. So if they have no other metabolic abnormalities and they want to do this also for their long-term health, that's a consideration, but then you also need to think about the side effects of that surgery and putting themselves at risk for that surgery in addition to a donation. So these are difficult conversations, and I think they're individualized, unfortunately, so I can't give a straightforward answer. I would never do that, or I would always do that. I think depending on the scenario, I might say that that would be okay. For example, if it's a mom to her child and her BMI is 45, and that's really important for her, and her child needs a kidney, that's a lot different than an 18-year-old who wants to give to their grandfather, and the 18-year-old, has a BMI of 45. I think we do need to take those types of things into consideration.
The only thing I would add to that is this often comes up, and it often becomes an artificial question, but I ask people, would you be considering this surgery in the absence of donation for your own health, right? And sometimes it becomes too convoluted because the two things are intertwined, but it's often a useful question because I think you do want to separate the person's understanding of their own health and why their motivations are to doing this, as opposed to meeting some artificial, cutoff so that they can donate a kidney. And I think that's a nuanced discussion, as Nicole's outlined.
I really like John's point about the follow-up and how I think that's evolving as well. And although we're required or mandated to have that 2-year follow-up, the reality is that's really not enough, because that's not the time when many of these donors are going to manifest some of their challenges, with kidney function. And so one of the practices that we really started is whenever we did have one of these donors that wasn't, an easy decision, we would then put them in sort of a program where we had strict follow-up with our transplant nephrologist at whatever intervals we felt were important. So whether it was a metabolic disease or, tendency or something else, hypertension for that matter, we would kind of put them in that pathway, which was in addition to what we were doing with the UNOS required follow-up.
Thank you. There is a question from someone from the audience specifically asking if directed donation was an option in 2017, and if so, how did it factor in the kidney transplant evaluation process? Did the survey address this? Dr. Garg?
Not sure. We didn't specifically ask. I mean, directed donation is definitely an option, but I'm not sure if they mean non-directed donation. But it was it is obviously an option, but we didn't specifically ask how it factors into the kidney evaluation process. No, the survey didn't ask that question.
All right. So in the survey, you also, in the metabolic evaluation component of it, you mentioned that nephrolithiasis is obviously a highly prevalent, and they're rarely cause of end-stage kidney disease, but obviously they are a concern for many of us when we assess living donors. And you mentioned that many programs may exclude potential living donors under the basis of the presence of even very small stones under 4 millimeters. So how do you decide, or who may need an evaluation and who does not for kidney stones?
Yeah, so in our program, what our experience has been, so anybody who has a history of symptomatic stone, which is debatable whether you can tell definitively or not. A lot of people will go to the ER with some belly pain history and be told that maybe they passed a stone, maybe it was something else. But I think if somebody has a history suggestive of passing a stone, they get a 24-hour urine analysis to look for their risk factors. In somebody who hasn't had any symptomatic stone history, but does have some CT findings, so for the really tiny stones, less than 2-3 millimeters, which are frequently referred to as Randall's plaques, they are considered to be a risk factor for stone formation. But if we only see just 1 or 2 of those, we don't necessarily do a stone evaluation for all of those, but anything greater than 3 millimeters buys, again, a stone risk evaluation. Having looked through a lot of these stone evaluation reports, most people, it's something you can easily guide. If you drink more fluid, you can reduce your stone risk, or somebody's citrate is low. So, adding a little bit of citrate can reduce the risk. But if a donor candidate has multiple risk factors, high calcium, high salt intake, low urine volume, low citrate, those would be very high risk for stone formation subsequently. And in the setting of one single kidney after donation and having a stone, an obstructive stone, can be really problematic. So wouldn't accept that, but most donor candidates usually have 1 to 2, relatively speaking, easily correctable factors. And if they understand the risks and as part of the informed consent process, we can usually help those donors get through donation. We do have the luxury of having a stone clinic at our institution. So a lot of these candidates can be referred to our stone clinic for long-term follow-up, who will do their 24-hour urine risk assessment post-donation if need be. But along these lines, the data on post-donation risk of stones is not, there's very little data on the aspects. So there's definitely room for more research, especially long-term research.
Thank you, Dr. Gill or Dr. Turgeon. Anything that you would like to add?
Not to the stone comment. Nicole, did you want to add anything for the stones? Or?
Well, yeah, I just think because patients who have stones don't necessarily go on as frequently as others to have kidney failure doesn't mean that we shouldn't pay attention to it. Because, as we recall, they have 2 kidneys. And so when they have 2 kidneys with stones that are causing trouble, they'll probably be okay for a period of time. So I think we need to keep that in mind. And I really like how that was outlined in terms of managing stones. And I think it's the ones who do have the severe abnormalities that we need to be careful of when we're evaluating donors for stones.
In general, we have a low threshold for a metabolic stone workup. So we don't differentiate the plaques versus 3 millimeters of stones. We have so we have a pretty low threshold to do a metabolic stone workup. I don't know that we would differentiate plaques from the size of the stone.
Same here.
So clearly a lot of variability between programs and what prompts a workup and what not.
Mm-hmm. Yeah, in general lines, we also, if there is a stone, regardless of the size, they will undergo metabolic workup evaluation. Okay. Going back to, again, the problem with measuring the GFR and having, is there, what do you think about measured GFR, not 24-hour carrying clearance, since these methodologies are becoming a little bit more available of actually using nuclear studies to measure the GFR? Is that something that the field should be moving forward as opposed to the more ubiquitous 24-hour urine collection? Dr. Gill?
I mean, I think that, we love to think that this is a bulletproof test, but as we all know, there's variability in those test responses as well. So you can't check your brain at the door. I mean, so, unless we're going to be doing inulins on people, which we're not, even measured GFR tests require, careful consideration. So, you can get quite even day-to-day variation. They are operator dependent. They are subject to the same things in terms of considerations of the patient in steady state and et cetera. So I think that, that's the main message. Having said all of that, I think they obviate some of the issues with the GFR estimation questions that we've already alluded to. So I think as part of a comprehensive evaluation of the person's level of pre and in fact, potentially post-donation kidney function, they can be useful. But they're not, a panacea for that's the right answer. I mean, they all have their nuances and variability between the tests.
Thank you. Right.
I just saw the question related to Dr. Smith had the question about non-directed donation, and it wasn't specifically addressed in the survey. However, the KDIGO guidelines, I'll just put this out there because it's on my mind, suggested that we would have the same risk threshold in our programs and it would be programmatic. That's not how I practice. I mean, we have seen evolving literature about the benefits of donation to both the donor and the recipient and how that gets factored in. And so whether it's a non-directed donor, certainly we've heard differences in terms of the age of the donor, but all of those things I think are part of our multi-dimensional assessment of the donor. So I think that, I think the question about non-directed donation was perhaps implying of whether we should have a higher threshold for somebody who the benefits of donation may be less clear. I don't think that, I think all our evaluation should always be individualized for the donor and the recipient. And in this case, when the recipient is unknown, if it's a non-directed donor scenario, that certainly, I think, comes into our decision making. I think it's not natural to say that it's not part of our evaluation. So I don't know if others have comments about that, but I think that's what that question was getting at.
Yeah, I agree with you, John. We sort of treat all donors the same, whether you're non-directed or directed, and then individualize what the needs are for that particular donor. So I'll just give you an example. Is probably about 10 years ago in our program, we did psychiatry consults on non-directed donors only, on every single one. And then if you were in the directed donor, you didn't necessarily have to have one unless you had, a challenge. And I started thinking about that, saying that doesn't seem right. Are you weird and crazy? I think we did think that for a while for the non-directed donors, but now we're realizing that people truly are altruistic. They really have good intentions. They're not crazy. They really want to help someone. And so instead of having that view, we came around with a view of how can we help this donor achieve their goals, but within what we think is medically and socially and other aspects ethically appropriate. And so it's up to your programs to decide that, but I really feel strongly that we shouldn't be treating them any differently than we do donors who are for directed recipients.
Thank you for the answer. So I see that we are right at the 3 p.m. mark, and thank you for the wonderful, conversation that we have. Thank you to our speaker and our panelists for today's audience for the wonderful questions that they posted. So I will pass on to Brian.
Thank you so much, Dr. Nishio-Lucar. AST would like to thank Drs. Garg, Nishio-Lucar, Gill, and Turgeon, and all of our attendees for today's session. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about the AST living donor community of practice, please visit myast.org/COPS or connect directly to the LDCOP hub.